Hi guys, good morning. So today we are going to discuss our first topic of the orthodontics, that is the growth and the development. Starting with this, first we will be discuss that what is orthodontic. See, basically orthodontics, it is the branch of dentistry which is concerned with the prevention, with the interception and with the correction of the malocclusion. Fine, and also with the correction of the other abnormalities of the dentofacial region. Fine, means orthos and odontos. So orthos, it means to correct, and odontos means the teeth. So basically orthodontics, it is the branch of dentistry that is concerned with the prevention, with the interception and with the correction of various malocclusion and other abnormalities of the dentofacial region. So before discussing the growth and development into detail, let's discuss some of the important points which are important for your exam point of view. So first is the term orthodontics. It was first coined by the Le Fallon. The father or the founder of the modern dentistry is the Pierre Fauchard. So Pierre Fauchard, he was a French dentist and he considered as a founder of a modern dentistry. He was the first one who developed the first orthodontic appliance, which was called as the Bandelet or the Bandeau. Right, guys, very important, previously asked MCQ. So third one is the father of the orthodontic. So Norman Kingsley is the father of orthodontics. He introduced the two appliances, the obturator and the headgear. Fine. So the obturator, it is a maxillary obturator, which is also called as the intraoral prosthetic device, which fills up the palatal cleft. Therefore, it provides a negative or a false roofing against which the child can suckle. So the Norman Kingsley, he introduced the obturator and the headgear. Father of the modern orthodontics. So in this, the Edward H. Engel, he is known as the father of the modern orthodontic. So the Engel contribution, it includes the classification of malocclusion and also the orthodontic appliances such as the pin and the tube appliance and the H-wise appliance. Again, important. Right? Last is the first certified orthodontist was the Charles Tweed. We also studied the Tweed's self-analysis. Right? He was the first certified orthodontist. So after this, let's discuss the growth and the development. So starting with the growth and the development, first is the growth. So according to J.S. Huxley, according to the Krogman, according to the Todd, according to the Moyers, according to the Morse, there are so many definitions of the growth. For example, according to the J.S. Huxley, the growth he defined as the self-multiplication of the living substances. It is the definition of the growth which was given by J.S. Huxley. According to the Krogman, the growth is there is an increase in the size, change in the proportion and progressive complexity. According to the Krogman, the growth is increase in the size, change in the proportion and the progressive complexity. And according to the Todd, the growth is an increase in the size. Now after growth, coming on to development, according to Todd, the development is the progress towards the maturity. This is what development according to the toy. Fine. So next we'll talk about the growth spurts. Very important. So basically, growth does not takes place uniformly at all the time. So therefore, there will be a specific period when a sudden acceleration of growth occur. That sudden increase in the growth, what we call as the growth spurts. Guys, please note it down. This is very important. Commonly asked MCQ, the timings of the growth spurts. So in this, the growth spurt, it occurs, number one, just before the birth. Second, 1 year after the birth. And in the mixed dentition, the growth spurts, it occur 8 to 11 years in boys and 7 to 9 years in girls. While in the prepubertal growth spurts, it occurs at the age of 14 to 16 years in the boys and 11 to 13 years in girls. Fine, important. Now after this, coming on to the terminology, that is the differential growth, DG, that is the differential growth. So what do you mean by differential growth? See, the different organs, they grow at different rates. I repeat, DO, that means the different organs, they grow at different rates to a different amount at a different time. This term is known as the differential growth. I repeat, the differential growth means the different organs, they grow at different rates to a different amount and at a different time and at different time. This is what differential growth means. So in this, first is the Scammonn's curve. So the Scammonn's curve, in this, the body tissue, it is broadly classified into 4 types: the lymphoid tissue, the neural tissues, general tissues and the genital tissues. Starting with the first, that is the lymphoid tissue. See, this is the Scammonn's growth curve. Fine. So this x-axis, it represents the years, while the y-axis, it represents the percentage of the adult size. First, we'll talk about the lymphoid tissues. Fine. So this curve, this is the lymphoid tissue curve. So in this, the lymphoid tissue, they proliferates rapidly. They proliferates rapidly. Important point, in the late childhood. This point is important. In the late childhood, and they reaches almost about 200% of the adult size. Again, very important, commonly asked MCQ. Fine. So the lymphoid tissue, they protect the children from the infection. Fine. So in this, important point, that by the age of around 18 years, the lymphoid tissue, they undergo the involution to reach to the adult size by the age of 18 years. Fine. Second are the neural tissue. So green one, this is the neural tissue. So the neural tissue, they grows very rapidly and they almost reaches the adult size. Commonly asked MCQ, the neural tissues, these are the tissue, they grows very rapidly, number one, and they almost reaches the adult size by the age of 6 to 7 years. Please note it down, very important. Fine. So in this, a very little growth of the neural tissue, it occurs after 6 to 7 years. It means the neural tissue, they grows very rapidly and they reaches to the adult size at the age of 6 to 7 years. But after 6 to 7 years, the very little growth of the neural tissue occurs. Right? Now next are the general tissues. So the general tissues, they follow the S-shaped curve. Follows S-shaped curve. Fine. So these are the tissue, they exhibit an S-shaped curve and The germinal tissues, they consist of the muscles, bones and other organs. Right? Important point is, I'm writing over here about the germinal tissues. So the germinal tissue, they follows the S-shaped curve, and there is a rapid growth which occurs up to 2 to 3 years. Therefore, after 2 to 3 years, in between 3 to 10 years, they follow a slow phase. Right? And at the 10th year, at the 10th year, there is a rapid phase occur. There is a rapid phase occur. Number 1, and they terminate at the age of between 18 to 20 years. They terminate. Fine. And last are the genital tissues. So this blue line, it indicates the genital tissue which consists of the reproductive organs. So they show a negligible growth until the puberty. However, they grow rapidly after reaching the puberty. Their growth increases. After reaching the puberty or at the time of the puberty, their growth increases, but initially there is declined growth of the genital tissues. Right? So after the Scammons curve, next is the cephalocaudal gradient growth. So cephalo means head and caudal means the feet. So it means the growth which extending from the head towards the feet. Right? So in this, the growth, it can be illustrated as following. Number 1, the head, it takes up about 50% of the total body length at about 3rd month of the intrauterine life. Fine. Second point, at the time of the birth, the trunk and the limbs, they grow more than that of the head. Therefore, the size of the head decreases to 30%. In the first point, the size of the head is of 50% of the total body length. In the second point, the trunk and the limbs, they grow more than that of the head. Therefore, the size of the head, it decreases to 30%. And in the third one, when the overall growth continues, there is a reduction of the head to 12%. It means, firstly, there is a 50% of the total body length of the head is 50%. Second, it reduces to about 30%. Third, it reduces to about 12%. Important points, note it down. Right? Second point, the lower limbs, these are rudimentary around the 2nd month of the intrauterine life. Third point, at the time of the birth, the cranium is larger than that of the face, and postnatally, as the child grows, the face grows more than that of the cranium. But at the time of the birth, the cranium is larger than that of the face. Now next are the method of studying growth. So in this we have 2 approaches. We have the measurement approach, we have the experimental approach. So the measurement approach, it includes the craniometry, which means the measurement of the skull. Second is the anthropometry, it means the measurement of the human individuals. Third one are the radiograph, you are taking cephalometric radiograph, and third one are the 3D scans. Next are the experimental approaches. So in this we have the vital staining. So the vital staining, it was first given by Belcher in 1936. He found that the bones of the animal, especially the goats, the bone of the animals that had eaten the madder plant, the madder plants, the bones were stained red. Why the bones were stained red? Due to the alizarin, very important, due to the alizarin dye. Fine. Second are the radioisotopes. So these are the certain elements or the compound. For example, the calcium 45, potassium 32. These are some of the radioisotopes or the compound. These are injected into the tissues. Fine. When these are injected into the tissue and they stain the developing, or they are incorporated into the developing bone. Fine. Next are the implants, which are important. Implants, it was first introduced by Bjork, commonly asked MCQ, in 1969. It comes under the longitudinal studies. Important MCQ. Fine. So implants, mainly he insert the tantalum metal implants. Fine. So these are biological inerts alloy which are inserted into the growing bones, the implants. So after this, coming on to the mechanism of the bone growth. So first is the remodeling. So in this, what is remodeling? See, the remodeling, it is a process of bone deposition at one end and bone resorption at another end. So together, deposition and resorption, it is called as remodeling. Fine. So the changes that the bone deposition and resorption it can produce, they change in size, they change in shape, they change in proportion. Fine. So the mechanism of the bone growth, it is of two types, the cortical drift and the displacement. So first is the cortical drift. So the cortical drift, it is a combination of bone deposition and bone resorption, which resulting in a growth movement towards the deposition site. This is what we call as cortical drift. Fine. See, in this, if a bone, it has a deposition and it has a resorption on the either side, the deposition is equal to the resorption, then the thickness of the bone is constant or equal. When the deposition is more than that of the resorption, there is thickness of the bone. When the resorption is more than that of the deposition, there is thinness, or the bone is thin at one end. Fine. Next is the displacement, commonly asked MCQ. Displacement is movement. Therefore, displacement is the movement of a whole bone as a unit. So in this, we have two types of displacement. We have primary displacement and secondary displacement. See, primary displacement is when a bone, for example, this is a maxilla. So when a bone, it gets displaced as a result of its own, this is called as primary displacement. Right? For example, the growth of maxilla at tuberosity region. Right? Secondary displacement, for example, this is the cranial base, this is the maxilla. So primary displacement was as if a bone, it gets displaced as a result of its own, and the secondary displacement, it means when a bone, it gets displaced as a result of, or the enlargement of the adjacent bone. For example, if there is an enlargement of a cranial base, it pushes the maxilla into the forward and the downward direction. So it means if a bone, it gets displaced as a result of the adjacent bone, this is what we call as a secondary displacement. For example, the growth of the cranial base, which causes the forward and the downward displacement of the maxilla. Right? So this is very important for your MCQ, commonly asked MCQ. Now next is the osteogenesis. Osteogenesis means the process of the bone formation. Fine. So the bone formation, it takes place in the two ways. Number one, through the endochondral bone formation to the intramembranous bone formation. Both are important for your MCQ. See, the endochondral bone formation means the bone formation, it is preceded by the formation of the cartilaginous model, which is later on replaced by the bone. It means first there is a formation of a cartilage, then the cartilage, it gets replaced by the bone. This is what we called as the endochondral bone formation. Example is the SHE. It means the stapes, the hyoid bone, the ethmoid bone and the incus bone. These are the bones in which these are later on get replaced by the bones. Second are the intramembranous bone formation. So in the intramembranous bone formation, in this the bone formation, it is not preceded by the cartilaginous model. In this the bone, it is laid directly into the fibrous membrane. So in this there is no cartilaginous formation. First is the fibrous membrane form, which was later on replaced by the bone. Examples, very important, are the maxilla, nasal bone, parietal bone, zygoma, vomer, lacrimal and the zygomatic bone. Very important. Right? So these are the bone formation, either through the endochondral bone formation, either through the intramembranous bone formation. Third one are the bone formation from both of the endochondral as well as from the intramembranous. This is the most is the mnemonic. M is for mandible, occipital, sphenoid and the temporal. These are the four bones in which there is both the endochondral and the intramembranous ossification is seen. Important. So next and the important are the theories. So first theory is the remodeling theory, which was given by Brach in year 1930. Please note it down, very important theories. Second is the genetic theory, which was given by Brodie in 1941. So the genetic theory, it states that the growth, it is controlled by the genetic influence. Third one are the sutural theory. It was given by Sicher, and the sutural theory, it states that the craniofacial growth, it occurs at the site of the sutures. Right? Fourth one is the cartilaginous theory. It was given by the James Scott, and the cartilaginous theory, it states that the cartilaginous sites throughout the skull, these are act as a primary centers of growth. Important. Right? I repeat, the cartilaginous sites throughout the skull, these are considered as the primary centers of the growth. And according to the Scott, the nasal septal, NSC, the nasal septal cartilage, it occurs or it acts as a pacemaker for the growth of the nasomaxillary complex. Again, important. Right? Next is the functional matrix theory. It was given by Melvin Moss. We'll discuss it later. Next is the servo system theory of the growth, and it is also known as cybernetics. So it was given by the Petrovic and the Chartier. So this servo system theory, it is a type of a closed loop in which the input, it is constantly changing with the time, and in this the input, it is constantly changing and the output, it is constantly adjusted, fine, in accordance to the input. This is what the servo system theory is. Next is the Van Limburg theory. It was given by Van Limburg in 1970. Now coming on to the functional matrix theory. So the functional matrix theory, or you can say the functional metric hypothesis, it was given by Melvin Moss. So in this, the growth of the skeletal components, these are largely depends upon the functional matrix and on the non-skeletal tissues. Right? So in this, the each of these function, these are carried out by the FCC, which means the functional cranial component. So the functional cranial component, it divides into two parts. the functional matrix and the skeletal unit. So starting with the functional matrix, it consists of the muscles, glands, nerves, vessels, fat, teeth and the functioning space. And the functional matrix, it again divided into the periosteal matrix and the capsular matrix. So periosteal matrix, it acts directly and actively. These two terms are important. The periosteal matrix, they act directly and actively upon the related skeletal units. Therefore it brings about the active, again important, active and the compensatory transformation. Examples are the muscles, the blood vessels, nerves and the glands. Important. Second part of the functional matrix is the capsular matrix. See, the capsular matrix, it occurs indirectly and passively, whereas the periosteal matrix, it occurs directly and actively. And the capsular matrix, this is the only difference. The capsular matrix, it occurs indirectly and passively on their related skeletal units. Second point, the difference is the capsular matrix, it brings about the passive transformation, while the periosteal matrix, it brings about the active transformation. So the example of the capsular matrix is the neurocranial capsule and the orofacial capsule. Neurocranial capsule, it covers, or it consists, or in this the cover consists of the skin and the dura mater. And second example of the orofacial capsule, in this the skin and the mucosa, they forms the covering. Fine. In the neurocranial capsule, in this the cover consists of the skin and the dura mater, while in the orofacial capsule, the skin and the mucosa, they forms the covering. Now second part is the skeletal unit. So all the skeletal units, these are associated with a single function. These are of two types, the macroskeletal and the microskeletal. So macroskeletal units is when the adjoining portion of a number of neighboring bones, these are united to form a single cranial component. For example, the maxilla and the mandible. The microskeletal structures, the microskeletal, it means when a bone, it comprises of a several skeletal units, these are termed as a microskeletal unit. For example, the mandible and the maxilla. But the microskeletal units of the mandible are the alveolus angle, condyle, gonial angle, mental and the coronoid. These are the microskeletal units which together forms a mandible. And orbital, pneumatic and the parietal, these are the again microskeletal units which form the maxilla. So these are the microskeletal units. So this is all about the functional matrix theory. Next is the, I'm writing here, the functional matrix theory revisited. Important, commonly asked MCQ. Right? So the functional matrix theory revisited, it has 4 parts, or these are taken from the 4 articles, you can say. The first one is the concept of mechanotransduction. Fine. Second, commonly asked, it was the bone as connected cellular network. Fine. Third is the genomic thesis. Fourth one is the epigenetic antithesis and resolving synthesis. These are the 4 parts of the functional matrix revisited. It was again given by Melvin Moss. Fine. This is the major difference between the functional matrix theory and functional matrix revisited. Next is the Van Limburg theory. So the Van Limburg theory, it is a multifactorial theory. Very important point. It was given by Van Limburg in 1970. So it combines all the three theories. They support the Van Limburg, it supports the theory of the Melvin Moss, and he suggested the 5 factors which controls the growth. It includes number 1, the IGF, it means the intrinsic genetic factors. So these are the genetic control of the skeletal units themselves. Second is the LEF, means the local epigenetic factors. In this, the bone growth, it is determined by the genetic control, fine, from the adjacent structure like the brain and the eyes. Third one is the GEF, which means the general epigenetic factor. So they are the genetic factor which determine the growth from the distant structure. Example, the sex hormone, the growth hormone. Fourth one is the LEF, which means the local environmental factor. So they are a non-genetic factor. Example, the habits like tongue thrusting, lip biting, nail biting, right, and your tongue thrusting, thumb sucking, right, and your muscle force. Last is the GEF, which means the general environmental factor. They are the general non-genetic influence. Example, the nutrition and oxygen, right. Last is the Ehnlof's expanding V principle. So according to the Ehnlof's, many facial bones, they have a V-shaped pattern of growth, which means this is the V-shaped pattern in which the deposition, it takes place at the inner side, whereas the resorption takes place at the outer side. I repeat, the bone deposition, it takes place at the inner side of the V, and the bone resorption, it takes place at the outer side of the V. This is what we call as V principle. Right? Examples, very important example is the ramus of the mandible, commonly asked MCQ. Very important, the ramus of the mandible, end of the long bones, mandibular body, palate, coronoid process and the condylar process. Again, very important for your MCQ. Fine. So after this, next are the branchial arch derivative. You can always expect a question from the branchial arch derivative in ortho. Please go through this table once, very important. See, first arch, Meckel's cartilage, the derivative or the cartilage is the Meckel's cartilage. Derivative is the sphenomandibular ligament, anterior ligament of the malleus. The bone involves the maxilla, mandible, malleus and incus. The muscles are masticatory muscles, temporalis, masseter, pterygoid, tensor palate, tensor tympani, anterior belly of digastric, and nerve involved is the fifth nerve, that is the trigeminal nerve. Second is the Richards cartilage, and derivative is the styloid ligament. Bone is the lesser cornu and the body of hyoid. Muscles are the muscles of facial expression, stapedius, posterior belly of digastric and stylohyoid, and nerve which is supplied by the facial nerve, that is the seventh nerve. Third is the bone involved is the greater cornu or the hyoid, bone of hyoid, or sorry, the body of the hyoid. The muscle involved is the stylopharyngeus, and it is glossopharyngeal nerve which is involved. Fourth and the sixth. Fifth one disappears. Fine. So fourth and the sixth, these are the thyroid cartilage and the laryngeal cartilage, or you can say the sixth cartilage is the cricoid cartilage. So in this, muscle involved are the pharyngeal muscle and the laryngeal muscles. Nerves are the recurrent laryngeal, spinal accessory and the pharyngeal branches. Fine. Next is the Meckel cartilage. Again, very important. for your MCQ. A number of question comes in your previous exam from the Meckel's cartilage. Very important point that the Meckel's cartilage, it is called as the primary cartilage of the mandible. Very important. The Meckel's cartilage, it is called as the primary cartilage of the mandible, not secondary, not tertiary, only the primary. So the Meckel's cartilage, it is derived from the first branchial arch around the 41st to 45th day of the intrauterine life. Again, important. Next is the Meckel's cartilage. It extends from the cartilaginous aortic capsule to the midline It extends from the cartilaginous aortic capsule to the midline or the symphysis, and it provides a template for guiding of the growth of the mandible. Fine. This is very important point. The major portion of the Meckel's cartilage, it gets disappear during the growth, but the remaining part of the Meckel cartilage, they develop into the mental ossicles, the incus and the malleus, the spine of sphenoid, anterior ligament of the malleus, the sphenomandibular ligament. Right? So after this, next is the terminology about the synchondrosis. Synchondrosis, it means the first of all, so next is about the synchondrosis. What is synchondrosis? It is the fusion of the two adjacent bone by a cartilage. Right? So the synchondrosis is that most of the bones of the cranial base, they are formed by the cartilaginous process, but later on the cartilage, it gets replaced by the bone. But however, certain bands of the cartilage, these are the bands of the cartilage, they are remains at the junction. This is the bone, this is the bone. So some bands of the cartilage, these are remains on the junction of the bone. These areas, these are called as synchondrosis. So basically the synchondrosis, it is the fusion of the two adjacent bone by a cartilage. So in this we have four types of synchondrosis. See, number one is the spheno-occipital synchondrosis. Important point that the spheno-occipital synchondrosis is the last chondrosis to fuse. So if a question comes, which of the following synchondrosis is considered as a last synchondrosis to fuse, so your answer should be spheno-occipital synchondrosis. Fine. So in this, it is a cartilaginous junction, this is a cartilaginous junction which is present between the sphenoid bone and between the occipital bone. This is the sphenoid bone, this is the occipital bone, and this is the cartilaginous band, which is called as the spheno-occipital synchondrosis. Right? Important point is that this is also called as the principal growth cartilage of the cranial base during the childhood. MCQ. And the direction of the growth is upward and forward. Upward and forward. Important point, the spheno-occipital synchondrosis, it active up to 12 to 15 years, and then it becomes fused in the midline area at the age of 20 years. Important, right? Second is the sphenoethmoidal synchondrosis. So the sphenoethmoidal synchondrosis, it means that there is a cartilaginous band which is present between the sphenoid, this is the sphenoid, and this is the ethmoid bone. So this is the cartilaginous band which is present between the sphenoid bone and the ethmoid bone. This is called as the sphenoethmoidal synchondrosis, and it is ossified by 5 to 25 years of age. again important. The timings are very important for your MCQs. Third one are the intersphenoid synchondrosis. So it is a cartilaginous band. This is the cartilaginous band which is present between the two part of the sphenoid bone. This is sphenoid, this is sphenoid. This is the cartilaginous band which is present between the two bones of the sphenoid. So very important, this is the first one which is ossified at the birth. So if a question comes, which of the following synchondrosis is ossified at an early stage, so your answer should be intersphenoid, which ossified at the time of the birth. Important. Last is the intraoccipital synchondrosis. So in this ossifies at the age of 3 to 5 years. Again important. Right? So after this, next are the important timings of the cranial base growth. So by birth it is 55 to 60% of the adult size which is attained. By the age of 4 to 7 years, 94% of the adult size is attained, and by the age of 8 to 13 years, 98% of the adult size is attained. Right? So after the synchondrosis, second is the synostosis. Second word is the synostosis, which means there is an early closure of the suture, early fusion of the two adjacent bone by the bone. So this is the fusion of the bone by the bone, which is called as synostosis. Example, the symphysis mentae. Next is the syndesmosis. It is the fusion of the two adjacent bone by a fibrous ligament. Right? So next is the development of the face. So the development of the face, it occurs, there are three planes. The transverse plane, it means this plane. This is your, for example, this is your molar, this plane, right? The lingual and the buccal. If this is the transverse plane. Second is the sagittal plane, it means this plane. This is the anterior, this is the posterior. So this plane is known as the sagittal plane. Vertical plane is your gingival and incisal. See, transverse plane is, for example, this is your molar, right? I'm talking about the mandibular molar. So this is, if it moves in this direction, in lingual direction and in buccal direction, this is the transverse plane. The sagittal plane is, suppose these are your maxillary anteriors or maxillary incisors. If they get proclined, it means they move in the anterior direction. If they are retroclined, it means they move in the posterior direction. So the anterior and the posterior direction, it is called as the sagittal plane. The vertical direction is the open bite. For example, this is your maxillary incisor, this is your incisal edge, this is your gingival end, right? So this plane, this is known as vertical plane, in which you can see there is an open bite and deep bite. This plane is vertical plane. So the development of the face occurs first in the transverse plane, then in the sagittal plane, and then in the vertical plane. Important. So next are the trajectories of the force. See, in this, the Mayer and the Kuhlmann in 1867, they both proposed the trajectorial theory of the bone, while the Benninghoff, they studied the natural lines of the stress in the skull. How? By piercing the small holes into the fresh skull. See, in this, we have trajectories of the maxilla, we have the trajectories of the mandible. The trajectories of the maxilla, it occurs in the vertical and in the horizontal direction. Fine. So first we will discuss about the trajectories of the maxilla in a vertical direction, or you can say the vertical trajectories. So it consists of FN buttress, it means the frontonasal buttress, the malar zygomatic buttress, and the pterygoid buttress. First we are taking the FN, that is the frontonasal buttress. So this trajectory, it originates from the incisor, from the canine, and from the first premolars, and they run cranially. It means cranially means towards the cranium, along the side of the piriform aperture and the crest of the nasal bone, and it terminates into the frontal bone. I repeat, the frontonasal buttress, the trajectories, they originate from the incisor, from the canine, and from the first premolar, and they run cranially towards the cranium, along the side of the piriform aperture, the crest of the nasal bone, and it terminates into the frontal bone. Second are the malar zygomatic buttress. So these trajectories, they stress from the buccal group of the teeth in the three groups. So first group, it involves through the zygomatic arch. This is the zygomatic arch to the base of the skull, number one. Second is upwards to the frontal bone through the lateral wall of the orbits. Third one, along with the lower orbit. This is the orbit, along from the lower orbit of the lower orbital margin to join the upper part of the frontonasal buttress. Right? I repeat, the FN buttress is clear. The malar zygomatic buttress, it is divided into the three parts, or you can say it has the three pathways. Number one pathway is through the zygomatic arch to the base of the skull. Second is upward to the frontal bone through the lateral wall of the orbit. Third one, along the lower orbit of the lower orbital margin to join the upper part of the frontonasal buttress. See this one. Fine. Third one are the pterygoid buttress. So these are the trajectories. That are transmitted from the second and the third molars to the base of the skull. These are the pterygoid trajectories. Fine. So these all are the vertical trajectories. Now coming on to the horizontal. So the horizontal, they include the HP, it means the hard palate, and the orbital ridge, zygomatic arch, palatal bone, and lesser wing of sphenoid. These are the horizontal trajectories. So this is all about the trajectories of the maxilla. Now coming on to the trajectories of the mandible. See in this, these are the lines of the stress that extends from one condyle to the another and passing on to the symphysis. Right? So in this also a number of vertical trajectories. These are radiate downward below the roots of the mandibular teeth. Right? Third one are these are the lower border of the mandible and the mylohyoid ridge and other prominent buttress of the mandible. So this is all about the trajectories of the maxilla and trajectories of the mandible. So next are the growth rotations, very important for your MCQ. There was a question in your June AIMS 2020 regarding the growth rotations. Fine. And in PGI also. See, the growth rotation, it was given by Bjork in 1955. So the rotation of the mandible, either it is in forward direction or in backward direction. So before discussing this, let's discuss some of the terminologies. First is the hypodivergent. Please understand it carefully. And hyperdivergent. It is always in relation to your mandible. Fine. For example, this is your mandible. Fine. When the growth of the mandible, it occurs in a backward direction. When the growth of the mandible, it occurs in the backward direction, so your mandible will look like this. So it means the growth is hyperdivergent. It means the patient's face is long and narrow, right? And if the growth of the this is your mandible, if the growth of the mandible is occur in the upward direction, so your mandible is like fine. So your mandible is like this. So in this, it is the hypodivergent, in which the patient's face, it looks broad and small. This is hypo. Hyper means this is your normal mandible. When your growth, it takes place in the backward direction or in the downward direction, so your mandible is something like this. It means hyperdivergent. The face is long and narrow. This is the main difference between the hypodivergent and the hyperdivergent. Hyper means long, narrow, the growth is in the backward direction, and hypo means broad and small face, the growth is in the forward direction. Fine. So after this, we have the two terminologies. Number one, the matrix rotation. What do you mean by matrix rotation? See, this is your cranial base, and this is your mandible. This is your mandibular plane. This one is your mandibular MP, mandibular plane, and this is your core of the mandible. Fine. When your mandibular plane, this plane, mandibular plane, it rotates with the cranial base, like the opening and the closing of the mandible. It is called as the matrix rotation. I repeat, this is a matrix rotation. It is a relation between your cranial base and your this one, your mandibular plane. When you, this is the mandible. Fine. When you close the mandible, when you open the mandible, the mandibular plane, it rotates like this and like this with relation to the cranial base. This is what we call as matrix rotation. Second is the intramatrix rotation. It means, intramatrix means inside the mandible. Inside the mandible. So this is your core of the mandible. This is your MP, that is your mandibular plane. This is your CB, that is your cranial base. Right? So in this, there is the rotation of the mandibular plane with related to the core. Rotation of the mandibular plane in relation to the core. Only this point. This is called as intramatrix. I repeat, matrix rotation is the mandibular plane, rotation of the mandibular plane with the cranial base. This is the matrix rotation. The intramatrix rotation means inside the mandible. So we are not considering the cranial base. We are not taking the cranial base. So the intramatrix rotation is the rotation of your mandibular plane in relation to the core of the mandible. This is what we called as intramatrix rotation. So the matrix rotation, it constitutes about 25%, while the intramatrix rotation, it constitutes about 75%. Third one is the total rotation. So it means this is the cranial base, this is the core, and this is your mandibular plane. So the total rotation means the rotation of the core with the cranial base, these two. The rotation of the core with the cranial base, this is what we call as total rotation. Right? I repeat, the matrix rotation is the mandibular plane rotates with the cranial base, like when you opening and closing the jaw. The intramatrix, so in this there is a rotation of the mandibular plane with the core of the mandible, and in total rotation the core of the mandible in relation to the cranial base. Very important. Now next are the rotations. See, in this we have forward rotation. It means the clockwise rotation. Right? In this we have the rotation around the condyle, which is type 1. See, this is your mandible, right? So the rotation is around the condyle, around here, right? When your rotation is around the condyle, so your mandible, it moves into the forward direction, right? When it moves to the forward direction, when the mandible it moves to the forward direction, it leads to the deep bite, right? Second is the rotation around the incisor edge or the incisor point. So this is your mandible, this is your mandible. Now your rotation is around the incisor edge, around here. So when your rotation of or your axis of rotation is around the condyle, so your mandible, it should move in this direction, like this, right? In this direction and in this direction. When your rotation, axis of rotation is at the incisor edge, so your mandible move in this direction. This is your center of rotation, or this is your axis of rotation, and your mandible will move in this direction, and it is free to move in this direction, right? And in the third one, when your axis of rotation is at the premolars, so this is somewhere around here, your premolars, right? So if this is the center of rotation, or you can say this is the axis of rotation, so this will move upward, the anterior surface it will move upward, and posterior surface it will move downward, right? So this is, there are the 3 points of the forward rotation. I'm repeating it again. First is the condyle, that is type 1. In this, if your axis of rotation is at the condyle or at the TMJ, then your mandible, it is move in this direction, right, which leads to the deep bite. When your axis of rotation is at the incisor edge, like in this direction, then it will move in the mandible in this direction. When your center or the axis of rotation is at the premolar, it will move in this direction, upward, downward. Right? Last is the backward direction. These are three types: type 1, type 2 and type 3. Now coming on to the second type, that is the backward direction. So in the backward direction, first is again at the condyle. So this is your mandible, somewhere around here. Then again it will move in this direction, right, in the backward direction, right. And second one are when your axis of rotation is at most distally erupted molar. It means this is your mandible and this is your most, these are your erupted last molars. So your axis of it will move like this is your axis of rotation, and then it will move like backward, forward. The upper portion will come forward and the lower portion, the mandible, it will come backward direction. Right? So this is all about the backward direction, about the forward rotation and backward rotation. Very important, commonly asked MCQ. Fine, I repeat it again. The growth rotation given by Bjork in year 1955. There is a rotation of the mandible in the forward direction or backward direction, or you can say there is a forward rotation and backward rotation. The hypodivergent, it means when the mandible it is grow in forward direction. Hyperdivergent, the mandible it is grow in the backward direction, which leads to the long and the narrow face. And we have the matrix rotation. There is a rotation of the mandibular plane in relation to the cranial base, for example the opening and the closing of the jaw. Second is the intramatrix, which is inside the mandible. So this is the rotation of the mandibular plane to the in relation to the core of the mandible. Third is the total rotation, which means the core of the mandible, there is a rotation of the core of the mandible with the cranial base. Right? So coming on to the rotation, forward and backward rotation. So in the forward rotation, first is the condyle. When your axis of rotation is at the condyle, your mandible will move in this direction. When your incisal, when your axis of rotation is at incisal edge, at type 2 it will move like this direction because center of rotation is here. And third, if it is in the premolar, it will move like this. Anterior goes upward, backward will come downward. In the backward direction, first is the condyle, same as that of the upper one, and when the center or the axis of the rotation is at the most distally erupted molar, in this the upper portion get forward and lower portion get backwards. Guys, this is all about the growth and the development. Very important topic. Please go through it once and try to make the notes. Thank you.